Good afternoon, everyone, and welcome to week 4 of the Geriatric Health Promotion Series. My name is Heather Wickline-Sanchez, and I'm the manager of the DeTourney Center for Healthy Aging here in the School of Nursing, and I'm representing today the Northwest Geriatric Education Center. I wanted to mention to you that you can get continuing education credit for this lecture, and your site coordinator has information about how to register to obtain credit utilizing the new online process. Today, we're pleased to have Dr. Joshua Benditt come talk to us about COPD, a growing epidemic amongst the elderly. Dr. Benditt is professor of medicine in the Division of Pulmonary and Critical Care Medicine. He has a long interest in patients with COPD and was the principal investigator for the National Emphysema Treatment Trial at the University of Washington, a study of surgery for COPD. He is interested in research designed at improving the care of patients with neuromuscular respiratory failure. These include patients with muscular dystrophy, ALS, spinal cord injury, as well as a variety of other disorders. He is particularly interested in advancing the frontier of non-invasive ventilation for these patients to improve quality and length of life. So welcome, Dr. Benditt.
Thank you.
Glad you're here.
Yeah, pleasure to be here. Great. Thanks, everyone all over the WWAMI region for being here today. I am a pulmonary doctor. I work here at the University of Washington Medical Center, and I have worked over the years with surgical treatments for COPD, as well as caring for patients with COPD with medications. I'm going to talk to you today about COPD, and the length of the whole session is 90 minutes, but I wanted to give you all a little break in between a couple of parts of the talk, and so what we'll do is I'll try to aim for about 35 to 40 minutes, and then we'll have a period of questions, and I think you can type in questions and we'll answer those. Take a brief break, and then come back for the second half, which will be aimed more at the treatment of COPD, including medications, current treatment recommendations, as well as surgical treatments for COPD. So this is a very, very big problem. As of 2014, COPD is affecting about 5% of the U.S. population, causes about 120,000 deaths annually, the third ranked in the United States, and by 2023 it's supposed to climb up at least another 1. It is a very common cause of office visits and resource utilization, and in the European Union they did a study last year, and it represented 6% of the total healthcare budget, 56% of the cost of respiratory diseases. So that's everything else, including asthma, lung cancer, fibrotic lung disease, etc. So it is a big problem. It is also growing compared to other diseases. This is from a website which is from the Global Initiative on Obstructive Lung Diseases, or GOLD, G-O-L-D, and I recommend this website for general information. But this was between 1965 and 98, and the trend has continued, but you see COPD has climbed by 163%, while coronary disease, stroke, and other cardiovascular, which has been the major cause of death in the United States, is dropping. I'll go through the reasons for this in a moment. This is a map looking at the frequency of COPD around the country, and I would say, fortunately, here in Washington at least, we have only 3.1 to at most 4.9%, but when you move towards the center of the country, they have up to 9.3% of the population with diagnosed COPD. So it is geographically distributed, and that has mostly to do with the smoking rates in those areas. Very unfortunately, women have now surpassed men in the rate of mortality from COPD. I remember when I was a kid, they had the Virginia Slims ad, "You've come a long way, baby." Well, very unfortunately, women have come a long way, and they are now equal to men. When I was a medical student and intern, there were still many more men with this. It's now equivalent, and women lead in terms of death from COPD. Now, why is this such a problem for older patients? And the reason is because as we age, the lung ages as well, and airflow decreases. So when you hit about 25 years of age, you have the maximum capacity of your lungs, and they age over time. And if you unfortunately happen to have COPD in addition, you get symptomatic much earlier. So whereas somebody now who's 90 might have pulmonary function that lends them to be a little bit short of breath with heavy exertion, for instance, if you have COPD and age, it will be much worse. COPD-induced, or cigarette smoking-induced COPD takes decades to develop, on average about 3 decades. So if you start smoking in your teens to 20s, it's not going to be until you're in your 50s where you start to have symptoms, and then because COPD worsens over time, you'll be in your 60s, 70s, and 80s when the symptoms predominate. So in fact, if you look at this, it is an adult disease, and it affects older adults predominantly because of the lag time from the initial insult. This is a study from Canada, but it is exactly paralleled by data from the United States, and what it shows is on the x-axis we have all ages here, then increasing 35 to 44, 45 to 54, and then 75 and older. And on the y-axis, we have the percent of the population who has it. And as you can see, for men, it's about 11.5% in Canada. For women, about 8.25% or thereabouts. So definitely increases with the age categories and for the reasons that I mentioned before. Now, what are risk factors for COPD? Well, in the United States, cigarette smoke is the major one, but environmental tobacco smoke is also a risk factor. Unfortunately, in our area, we have limited where people can smoke, which is very helpful, but also indoor and outdoor air pollution and occupational dust and chemicals. But it's on the background of a genetic predisposition, and this is not completely understood, but only about 10% of heavy smokers get COPD. And the reason they get it is because they have a genetic predisposition. We are starting to understand some of the genes, and a lot of them are what are called metalloproteinases that can affect inflammatory cell function in the lung. Infections can make this worse, and in fact, I'll show you data later on where bacterial infection can lead to worsening inflammation and COPD. And then socioeconomic status. So unfortunately, lower socioeconomic groups are exposed to more environmental, dust, smoke, etc., which can make COPD progress more rapidly. And as I've said before, aging of the population is also a risk factor. This is another slide just looking at a little bit differently of the pathway to COPD. So genes, a noxious agent, which in the US is tobacco smoke, respiratory infections, and other triggering the onset of COPD. Now, if you go out of the United States to the developing world, what you see is that the etiology of chronic lung disease is not necessarily smoking, but often indoor air pollution. So cooking in South America, Africa, Southeast Asia often happens inside in poorly ventilated areas where there are lots of particulates and hydrocarbons that can cause what initially looks like bronchitis that can lead to chronic airway obstruction. And so not only do we have the issue of, say, for instance, China, where cigarette smoking rates are climbing dramatically, but also indoor cooking in the rural areas. So it's kind of a two-pronged etiology. This shows you, if you are interested in the biochemistry of this, how COPD comes about. So if you are exposed, for instance, to cigarette smoke and have the genetic susceptibility, what happens is that you get inflammatory cells that come into the lungs, into the air spaces. CD8 positive lymphocytes, which are a subgroup of lymphocytes, and alveolar macrophages come into the alveolar spaces, the air spaces at the distal portion of the lung, and they activate neutrophils, which are cells that are normally used to kill bacteria, viruses, etc. The neutrophils release proteases, and in particular one called elastase, which starts to cause inflammation and breakdown of the lung tissue. What happens is that you get airway inflammation and remodeling, tissue destruction, and that all leads to this final common pathway of airflow limitation. And I'll go through that in a moment in greater detail, but it means there's difficulty in getting air out of the lungs, which is basically what leads people to develop shortness of breath with COPD. If you were to look at a microscopic cross-section, what you would see, this is an airway here, and you'd see inflammatory cells as well as thickening of the airway and mucus hypersecretion, so extra secretions in the airway. And in addition to that, you would see the breakdown of what are called the alveolar septi, which are the fibrils that basically keep the airways open and also allow gas exchange to occur. So you have two things. You have the creation of big dilated air spaces, and we call that emphysema, and you have airway narrowing and hypersecretion, and that leads to chronic bronchitis, so cough and sputum production. And over time, the airways start to fibrose. They get thickened and actually scarred down. An important thing to realize is that the inflammation that we see in COPD is not the same as the inflammation in asthma, and that'll have some implications for treatment of patients with COPD. So what I'm going to do now is just present a case so you can think about it on your own. Obviously, since we're scattered all over the Northwest, we can't answer and talk together, but I'm just going to let you think about this before I go into the explanation. So this case is one in which I'll ask the question, does this patient have COPD based on what you know here? It's a 56-year-old male smoker who comes in complaining of intermittent productive cough over the past 3 years. He was given a puffer in the past, which he thinks may have helped. His chest x-ray is reported to show mild hyperinflation, so increase in the size of the lungs. And that's all you know. So the question is, does this patient meet the definition for COPD? Okay. I would say that no, the patient does not meet the definition of COPD, even though the history and even the chest x-ray are suggestive. So the patient comes in with shortness of breath, has cough that's productive of sputum, has the risk factor, but in order to diagnose obstruction of airflow out of the lung, you have to do spirometry, all right? And now the GOLD committee, which is really a committee that was set up by the World Health Organization and the NIH, I believe, and CDC, has said that in order to diagnose it, you have to have spirometry. You cannot call somebody to have COPD without having that. So what does this mean? Well, it basically means that in order to label somebody with that diagnosis, you have to show that if you take the forced expiratory volume in 1 second, how much you can breathe out in 1 second, and if you divide that by the size, the volume of the total breath that you can breathe out, if that is less than about 0.7 or 70%, you have airflow obstruction. So, any one of us sitting in this room or out in the other sites, if you take a breath in, blow it as hard as you can, about 80–85% of the breath comes out in the first 1 second. If you have airway obstruction, blockage of airflow out of the lung, it will take longer for you to get that air out. So the fraction that you can get out in the beginning of the breath starts to go down. The breath gets bigger, and the amount you can get out per unit time gets smaller. So, if somebody is 45 years of age or older, they have a chronic cough, sputum production, exposure to risk factors, they're suggesting that you do spirometry. Now, this actually can be done in a primary care office. You do not have to send them to a fancy pulmonary function lab. And this is the type of machine that really should be used for screening. And what happens is here we have time in seconds. This is volume in liters. You take a breath in, you put your mouth, excuse me, I need to use that, right here, and you blow out as hard as you can, and what you get is a tracing that looks like this. Air starts to come out, and then as you push harder and harder, less and less air comes out. And if you look at the amount that comes out in the first second, it's a huge amount, you know, almost the whole breath. When you have obstructive lung disease, you get a lot less air out in the first second. And in this case, the amount that comes out in the first second compared to the total breath size is only 58% or 0.58. And the normal, again, is above 0.7. This is the way to diagnose obstructive lung disease. Now, just because there's obstruction doesn't mean it's COPD. People with that who have asthma may have that. People who have bronchiectasis may have that. But with the finding of age, risk factor, history of sputum production, dyspnea, and this finding, the diagnosis of COPD can be made. All right. Now, let's move on to looking at this GOLD, G-O-L-D, Global Initiative for Obstructive Lung Disease in a little more detail. What they've tried to do is to classify COPD into severity groups, first of all for studies, scientific studies, but also to guide treatment and evaluation. I'll show you in the second half of the lecture how that's used. But it basically is divided into mild, moderate, severe, and very severe, and that's based on the amount of breath that comes out in 1 second. So we know for me, for instance, that my FEV1, the amount that should come out in the first second, should be about 4 liters, give or take. If I turned up at 3 liters, right, that would be 3 divided by 4, 75%. So I would have GOLD stage 2 or moderate COPD because I fell between 50 and 80, all right? This is based on the FEV1, not the ratio, not that fraction, but really just the absolute value and percentage of what I should be or percent of predicted. And if it's greater than 80% of what I should be, I'm mild. 50 to 80 is moderate, 30 to 50 is severe, and very severe is less than 30. And that has implications when we get to treatment, both in terms of the schematic of how we should treat, as well as for qualifying for things like lung transplantation and lung volume reduction surgery. If you had to take away one slide from the whole talk, I would say this is the one. I hope it's come out okay on your handout. You're not in color there, but basically, this is the therapy and staging of COPD, and what you have across the top is the symptoms and the pulmonary function testing, the FEV1, and you go from asymptomatic, normal spirometry, to the mild, moderate, severe, very severe, and then we stage them. So stage 0 might be somebody who's 48 years old, who smokes a lot, has a cough, but when you do the spirometry, they don't make the cutoff. So they're at risk. The reason it's so important there is because if we can get them to quit smoking, we can have a dramatic impact on the likelihood of them developing symptoms over time. So it's important to identify those people. Obviously, then the mild is the greater than 80, moderate 50 to 80, etc. We're going to go through these in detail, but basically when you are stage 0, what you're going to do is quit smoking. And if you happen to cook indoors over an open flame, you better stop that, okay? And if you live next to a bus station and there's diesel particulates coming out, you might want to consider moving somewhere else. So avoiding the risk factors, and we give them an influenza vaccination because they are at significant risk of hospitalization from flu. We don't necessarily give them a pneumovax because it hasn't been proven to improve outcomes. But then, as you go from mild, moderate, severe, and very severe, you start adding medications. And at first, you start with short-acting bronchodilators. You then go to longer-acting. We then add more than one long-acting bronchodilator. Then we add inhaled corticosteroids. And along the way, we're certainly looking whether they need oxygen, and then in the final stages, do they need surgery? I find this a very helpful diagram. They have changed it last year, and I'll show you how they changed it. I find the new one very unhelpful, so I use the older one, and it really says almost exactly the same thing. I like this. I teach it to the medical students. I think it's extraordinarily helpful. All right. Ooh, that didn't come out well, and I apologize. This is important data, and I'll walk you through it. I do not know why that looks like that, but this from the lung health study, which was a long-term look at people with who smoked and had airway obstruction, and basically what it showed is that if you kept smoking and you had airway obstruction, the decline in pulmonary function was very steep. If, on the other hand, up here, excuse me, let me see if I can, up here, okay, you quit smoking, your pulmonary function declined at a much less steep rate. Even if you quit intermittently, it was better than continuing to smoke. And so I use this to say, okay, even if you failed once, it is worth trying again because over time you will have less decline in function. It is very clear for people who have COPD and continue to smoke that the rate of loss of lung function is very high and will get them to the point of dyspnea, even at rest, much sooner. Okay. So, what about smoking cessation? And I'm sure some of you have had experience with this. It's very difficult, and even with all the medicines that we have and behavioral modification, etc., the rate of recidivism or restarting smoking is very high. It's well over 50%, even with the best techniques. But for primary care practitioners, what we want to do is kind of use these 5 A's. So if you have smokers in your clinic population, you want to ask every time every visit, do you smoke? You would then advise them to strongly urge quitting. You would assess, determine their willingness to make a quitting attempt. And there are a lot of people who for quite a while won't want to attempt to quit, and there's not much you can do for them. But once they agree, yes, I'd like to quit, then you can start getting programs into action. And we have, our pharmacists have set up a lovely kind of clinical program to help them quit smoking, and certainly around the Seattle area there are many smoking cessation programs, many of which will prescribe medicines if needed. And then lastly, to schedule follow-up contact, and supporting the patient through the quitting process is important. And as I've showed you, if they have COPD, it can be extraordinarily important. Okay, so let's move on to talking about treatment of COPD. So a 60-year-old man comes to your office having been diagnosed with COPD, with spirometry, symptoms, etc. He's using an albuterol inhaler 3 times a day, so a short-acting bronchodilator, beta agonist. His FEV1 is 54% predicted. So that would put him in that moderate category that we talked about. So he's using albuterol. That's the only medication. Is that adequate treatment for him? Let you think about that a moment. Okay, and I think you'd say no, based on what I showed you earlier, which are the recommended treatment regimens. And we use short-acting bronchodilators really as a solo agent when you have mild disease. We continue to let them use it as needed, and I always use this really as kind of a rescue inhaler, or when they want to do some activity and they know they're going to get short of breath, to take it before they do that. So we'll let them use it through very severe, but we start adding other agents. And so for moderate, between 50 and 80, and those people will be more symptomatic. They'll be saying, geez, despite the albuterol, I just feel short of breath almost every day. So you add a long-acting bronchodilator, and it can be more than one. And in fact, there are now starting to be combination agents of long-acting bronchodilators. We'll get to the inhaled corticosteroids, but those are really reserved for people with severe and very severe COPD. So here is something you do not need to memorize. These are medications which are available for COPD, and I'm going to go through each group, so you'll have those references. There's been kind of an explosion in the past 2 to 3 years of agents. There are inhaled beta agonists, which are short-acting. So beta agonists bind to the epithelial beta receptor, and that causes bronchodilation. And if they're short-acting, we call them SABAs, or short-acting beta agonists. If they're longer-acting, and they've been able to modify them chemically so that they hang around longer, they're calling LABAs, or long-acting beta agonists. We also have anticholinergic agents, so there are also cholinergic receptors on the airway cells, and if you block those, you will get bronchodilation. So they're short-acting muscarinic agents, or anticholinergic because they're muscarinic receptors, and they're long-acting muscarinic agents as well, or LAMAs. So they're SABAs, LABAs, SAMAs, and LAMAs. Now, of course, manufacturers have decided we'll put drugs together, and which they like to do. I got a question from one of the sites. These are just each individual categories. I'm going to show you the combinations in a moment, but what I'm going through up here, these 4 are independent agents, single agents. But there are combinations. There are a combination of short-acting beta agonists and long-acting muscarinics. There are combinations of long-acting beta agonists and inhaled corticosteroids. There are inhaled corticosteroids on their own. There's something called phosphodiesterase 4 inhibitors, PDE4 inhibitors. We'll talk about those in more detail. And then there's theophylline, which has made a little bit of a resurgence. It's one of the oldest medications that we have. It has come back a little bit. And I'm going to now go through each of these in a little more detail. Okay. So let's start with the inhaled short-acting beta agonists, the SABAs. In the United States, we basically have albuterol, which is Proventil or Ventolin brand name, but we also have something called levoalbuterol, which is Xopenex. Xopenex is the R enantiomer of albuterol, and it was supposed to have less, and I made an error there, it's beta-1 side effects. Beta-1 side effects, which is the heart stimulating and the tachycardia response. And that was thought to be reduced with Xopenex. But in fact, when you look at the standard doses, there's almost no difference in the heart rates. It's more expensive, and so really this is all you need to use. What we do with these LABAs is use on an as-needed basis. So, gosh, I got short of breath walking up the stairs. Okay, yep, let's take that, feel better. If I know I'm going to go out and do shopping and I want to prevent it, I use it then. But I don't just schedule it and do it every 4 hours. Because if you do have that, it's suggested that you go to a long-acting beta agonist. Much easier for the patient to take and a much smoother kind of symptom course. There are reports of cardiac arrhythmias that are likely higher with regular use of the short-acting beta agonists. There's also been controversy about the long-acting beta agonist, but data to date, I would say, seems to show that that's not a great effect. I'll talk about that more in a moment. All right. There are also inhaled short-acting anticholinergic or antimuscarinic agents, SAMAs. So ipratropium bromide, which is Atrovent, is actually been shown to be equivalent to short-acting beta agonists in controlled trials, and it's synergistic to the short-acting beta agonists in terms of lung function, which is why the combination agent of Atrovent and albuterol was used for many, many years. It's short-acting, but they were working together. It's interesting that, in fact, in head-to-head trials with the older beta agonists, these ipratropium, etc., improved FEV1 more, although they never became popular as a first-line agent. I do not know why that is. But in the last 15 years, and much more so recently, there have been developed longer-acting beta agonists. So the original one was salmeterol, which is brand name Ceravent, but now we have formoterol, which was used in Canada and Europe, also known as Foradil. There's arformoterol, which is called Brovana. I've had many patients come into me and say, I want Brovana. There's no data that it's better than any of the others. Some patients prefer nebulized medicine. Again, no evidence that nebulization is better than a metered dose inhaler. There's one called indacaterol. There's valenaterol. If you look at these, they're very similar to the long-acting muscarinic agents when used alone. They have additive effects when used with the muscarinic agents, which is why for the moderate and severe, we would use more than one agent, but of a different class. So a LABA and a LAMA. Okay. Here are the long-acting muscarinic agents. The oldest one is tiotropium spiriva, but there's aclinidium tudorza that's just come on the market, umeclinidium anoro, which is combined with a LABA, glycopyrronium, which is used only in Canada. These are all once daily, all right? And they're easy for the patients to take. They're effective in improving PFTs and symptoms, and they are additive. as I mentioned. Just like the LABAs and the SABAs, they were also thought maybe to stimulate the heart more, but in a big trial of 17,000 patients, there was no increased mortality. They can cause urinary retention because anticholinergic to the bladder can cause urinary retention. It's unusual. In fact, I have not ever had that as a side effect. What about inhaled corticosteroids? This has been a debate in COPD as long as I have been in this field. For asthma, because the inflammation is very responsive to steroids, they are one of the first-line agents. So in younger people with asthma and older people, we use steroids frequently. But in COPD, even though they've been used for a long time, there hasn't ever really been any data that they influence outcomes in terms of mortality rate, and they have side effects. So, a Cochrane database systematic review in 2012, looking at 55 primary studies with over 16,000 patients, the rate of COPD exacerbation when you used inhaled steroids was reduced by 0.26 exacerbations per year, a quarter of an exacerbation, but the pneumonia risk increased 1.56 times. So 1.5 times the chance of getting pneumonia, even if you had a quarter less exacerbation. You had more likelihood of oral candidiasis, thrush in your mouth. The mortality rate was not different at all, neither was the FEV1. So GOLD recommends that you add inhaled corticosteroids only for people who have a lot of exacerbations. And that's how I do it. The problem is that one of the most commonly used combination agents has a salmeterol plus an inhaled steroid together, right? And that's how it's sold. And so a lot of people start people out on inhaled steroids almost from the beginning of their disease. It's an unfortunate thing of the way that the manufacturers put these things together, but there you have it. What about PDE4 inhibitors? There's one on the market in the United States. It's called roflumilast. What they do is they prevent breakdown of cyclic AMP in cells, and they have a modest bronchodilating effect, but they also cause tremendous GI side effects. I've had 2 patients on it, and they had tremendous bloating and diarrhea, which is not something that you want in people who can't move very fast. There are actually 2 agents now available, salomilast and rolopram in the United States. The recommendations from GOLD and others are that you use these when other agents are not as effective. Okay, what about theophylline? Theophylline actually can help shortness of breath, and it can improve pulmonary function as well. The problem with it is that the therapeutic index is low, right? So between having a seizure and dying and having, a therapeutic level isn't that great. Cardiac arrhythmia and seizures. Recommendations are that you add it only after you've had long-acting beta, long-acting muscarinic, steroids, and maybe even the PDE4. All right, so here's what we just went through. Again, inhaled steroids if repeated exacerbations. Now, we're almost done with this portion. Oxygen therapy. Oxygen is one of the only medications that has been shown to improve survival in COPD. All those medicines, all those billions and trillions of dollars that we spent on all of those have no effect on mortality, but oxygen does. So this is combination of what was called the nocturnal oxygen therapy trial and a British study called the BMRC trial. And these are people who had COPD, who had a PO2 less than 55 or SAT less than 88, who did not use oxygen. This was 12 hours per day, 15 hours per day and as close to 24 hours per day as you could get. And what you can see is that the survival was dramatically increased with oxygen. Therefore, for people with moderate or greater COPD, we suggest checking oximetry at every visit to look for a SAT less than 88, or if you prefer doing blood gases, a PaO2, arterial O2 of 55 or less. However, if you have side effects of low oxygen like polycythemia, pulmonary artery hypertension, or cor pulmonale, CMS, Medicare, will give you a little bit of the benefit, and your PO2 can be 59 or SAT 89%. This is the new gold recommendation. I do not like it at all, but I wanted to put it in for truth in advertising. You have A, B, C, and D categories. Along this axis, you had gold 1, 2, 3, 4. This axis, you had exacerbations per year. And on the x-axis, you had a dyspnea questionnaire, how short of breath you are. Far too confusing. I never ask these questions in clinic, but if you were to go to the website, you would see this is the most recent iteration. I do not know why they did that, but there you have it. And so, truth in advertising, I'm showing you that. All right. So, why don't we take some questions? If people want to type in things, let's take a few minutes of questions, and then if people want to stand up and stretch and all that, we'll get started at 10 of 5. Yes.
I use a, and I think you probably want to repeat the question.
Sure, I will repeat it.
I have a pocket spirometer. It's a digital pocket spirometer. I use just for, it doesn't do, it doesn't predict. It predicts and then does a basic screen. What do you think of that? And then if it's positive, then
So what you have is a little peak flow meter. Okay. Well, peak flow correlates with a FEV1 and a FEC. I don't remember ever seeing a study looking at kind of screening, you know, the first part.
Well, it gives FEV 1, 2, 3.
Oh, it does.
It gives vital capacity.
Oh, well, that's great.
But it wouldn't be diagnostic.
Is it an electronic?
It's battery powered.
Oh, well, I think it depends on the reliability of the device, if it's been studied and shown to be good. We let our lung transplant patients go home with a little, what we call a microspirometer, and they're accurate. Those ones are fairly expensive, so I don't know about your particular one, but if it measures FEV1 and FEC, that's what we're looking for. So, okay. Okay. So I have a question. Were you referring to Saba-Sama combination rather than Saba-Lama? There are Saba-Sama in the, when I was talking about albuterol and Atrovent, those have been combined. They are called Combivent, right, is the trade name. It's a short-acting one, so you have to take it 4 to 6 times per day. The longer-acting combinations, of which there are only a few at this time, and I'd have to go back to the slide, but are taken once per day. So the basic difference from them is the half-life on the receptor. So there are short-acting betas and samas, and then there are longer-acting betas and lamas. And you can go back to the slide to look at those, but there are fewer of those. All right. Okay. If a patient is on a scheduled LAMA, should the rescue combo Sama-Saba be changed to Saba? Yes, that is a great question. So somebody online says, okay, you're on a long-acting muscarinic agent like tiotropium, and you're using Combivent or Atrovent and albuterol combination as a rescue. Should you just go to the beta agonist? And the answer is yes, because the short-acting one will actually compete with the long-acting muscarinic agent, actually bump it off the receptor, so it kind of defeats the purpose. So yes, I do switch them. When I go to the LAMA, I switch them to a SABA for the rescue inhaler. Okay. All right, Olympic Medical Center. Do you switch from SABA to LABA as the patient progresses to gold 3 and 4? Yes, I do, but I let them stay with the SABA. It does not compete off the LABA. The SABA does not compete the LABA. So I give them the rescue inhaler, but they're on a long-acting beta agonist or a long-acting muscarinic. So even in the very severest form, stage 4, very, very severe, I still have them with that short-acting LABA. So my kind of preferred way nowadays would be somebody's mild, but they're going to progress, we know that. So you start them with the short-acting beta agonist. And then as they progress, then you would add in, and it doesn't matter which, a long-acting muscarinic or a long-acting beta agonist. And then if they're continuing to progress, symptoms aren't well handled, then you'd add the other class. So you'd have them on a long-acting beta, a long-acting muscarinic, and a rescue inhaler, which was a SABA. If then they start coming in with frequent exacerbations, etc., I would add an inhaled corticosteroid. And then, if they're really not doing well, I would try the PDE4 inhibitor. Although, again, personally, I've not had great success with that due to the GI side effects. Oh, okay. Would a restrictive diet help prevent or treat COPD? Do certain vitamins or supplements have impact? Great question. As far as we know, there is no diet that helps prevent COPD. They have tried vitamins, vitamin C, and that has not been effective. There's no preventive other than smoking cessation that is known to be effective. So no dietary stuff at this point. Okay, so what would you expect the O2 sats to be for someone at 7,200 feet elevation? I don't know exactly. You can calculate it if you know the atmospheric partial pressure at 7,200, which I don't happen to know off the top of my head, but we could calculate it. I'd have to look it up online, and I can't at the moment. But your normal person at 7,200 will probably be down or in the low 90s, I would say. But I'd have to check that to be sure. Let's take a 2-minute break, okay, and then we'll get back to the talk. Now, one thing about the that question is when you have a trach-in and you're using inhalers, some of the medicine can actually get caught on the plastic, so you may have to use more puffs than you would normally. So that may be the reason for increasing usage. The issue with what's the future, I can't say since I don't know the patient, but it depends really on why the tracheostomy was put in, more than likely, and what the other medical problems are, I would say. So I'm sorry to be wishy-washy, but I can't, I don't have enough information. All right, I have a patient who believes that it's better to train his lungs to recover during shortness of breath rather than using oxygen. Is there any evidence for or against this theory? There's no evidence for that theory. If the patient has really significant desaturations, it puts a strain on his or her heart, and it can generate arrhythmias, which would definitely not lead to longer survival. So it depends on how low it goes, but not using oxygen if you need it, I don't think is a good idea, and it doesn't train you. Okay, one last question, and then we'll move ahead. The trach was put in due to COPD, which it turned into lung disease. Okay, so the trach for COPD. Trachs for COPD are usually used in more advanced disease where there's a problem getting secretions out, or they need mechanical ventilation. So again, it kind of points to more severe, but I can't say again, and I don't want to practice online. Okay. Air Force Academy is about 7,200 feet. P is 590. Okay. After the lecture, I can calculate what the normal arterial O2 should be for an unaffected person. But just so we can finish, I'm going to start the lecture, save your questions, and we'll, at the end, if I need to go over longer, that will be fine with me. Okay. So we talked about the treatment regimens. The definition of acute exacerbation, which is very important for these people. So COPD, right, it's a chronic disease, it's there every day, but it can get worse, and it can get worse for a number of reasons. And what we define an exacerbation, and I'm sure all of you have seen these, is a worsening of respiratory symptoms above their baseline. And Nick Antonison, who was a researcher in this area, classified them into 3 parts. You don't need to know these. They're used mostly for research, but it's usually when there are 2 or more of dyspnea, increased sputum volume, or change in the sputum culture. Most of these are caused by viral infections. Most are due to rhinovirus, but bacterial infection occurs in about 30 to 50% of patients because COPD patients are often colonized with bacteria in their lower airway. So any one of us, from the vocal cords up, we have bacteria, but from down below, we should not have bacteria routinely. What they do is they get inflamed due to the viral infection, and then the bacteria that are living in their airway infect the lungs, and it'll cause, as I show you, worsening of lung function. There can be nonspecific triggers, so air pollution, days when the air pollution gets really bad in the summer, sometimes even weather, cold weather, dryness can cause exacerbation. The issue with the exacerbation is that it makes the inflammation that I described before much, much worse, and patients who have frequent exacerbations seem to have different and worse inflammation than even at baseline. And if you look at interleukin 8 levels, people who have more exacerbations, 3 or more per year compared to 2 or less per year, have much higher levels of circulating IL-8. And in fact, people are looking at antibodies to specific inflammatory molecules as a treatment methodology for these patients. If you have bacterial infection, this leads to kind of a bad cycle. So here are bacteria in the sputum of somebody with COPD, and what you can see here is that the bacteria cause an influx of white blood cells, polys here, macrophages, and what that does is it just worsens the tissue damage, gives you impaired lung defenses, and then you just get this cycle. So infections seem to cause exacerbations to be even worse and to damage the lungs even further. If you look at patients with a higher frequency of exacerbation in a given year, it predicts higher frequency in the next year and a much worsening loss of lung function, and it contributes perhaps a quarter of the decline in lung function of patients with COPD, and in fact, we can even start to predict mortality based on the number of exacerbations per year. Here is from 2002. On the y-axis, we have the FEV1, on the x in years, infrequent exacerbators, frequent exacerbators, and what you can see is that the infrequent have a slower loss of FEV1 than the frequent exacerbators. So more exacerbations, worse decline in lung function, so we want to prevent those, and that is one reason that we use the inhaled steroids for those who come in with exacerbation. The quality of life is terribly impaired if you have exacerbations. So symptoms, activity, impacts on life. This is the SGRQ score, the total, and each of the subscores. And if you have exacerbations, you're worse on that quality of life rating. So how do we evaluate these people? They oftentimes come to the ER, but they might come to you in clinic. So the history is really of the sputum amount, and is it increased? Is there a color change, and is it associated with shortness of breath? When this happens, I consider the patient as having an exacerbation, and I will treat them either with antibiotics, which has been shown in a Cochrane review to improve slightly the outcomes, or sometimes a burst of oral prednisone. What you'll see on physical exam is shortness of breath, tachypnea, tachycardia, fever, work of breathing. They're using their accessory muscles, abdominal paradox where the diaphragm isn't working and has fatigue. We'll often get a chest x-ray to make sure there's no pneumonia, because these people, if there is a pneumonia, are at high risk of not responding to antibiotics at home. We may get an arterial blood gas and a sputum sample. We admit them for the following reasons: if there's an inadequate response to outpatient or ED management, a marked increase in shortness of breath over baseline, or you have severe underlying COPD, so your FEV1 is less than 50%. And some people use an inability to sleep or eat due to symptoms. So if a person says, I can't eat because I get so short of breath when I eat, it's probably reasonable to admit them. We also admit them if there is worsening hypoxemia, acidosis due to hypercarbia, high CO2, if they have a change in mental status, which is common when the CO2 goes up. Sometimes if there's not enough support at home to make sure they're getting their medicines, etc. If they've had a lot of exacerbations in the past, or if there are high-risk comorbidities like heart failure, cardiac arrhythmia, etc. All right, so talked about outpatient management and all those medicines. What about inpatient? So here's a case. A 72-year-old female comes to the ER. She meets criteria for admission on what we talked about. You're writing orders for her admission. What COPD specific medications would you include? I'll let you think about that for a moment. All right, okay. Here's what I would use, all right? I would use short-acting bronchodilators in the emergency department, and you can use the SABAs and the SAMAs, and you can use them in a nebulizer if the patient is not able to coordinate the actions for the metered dose inhaler, the powdered formulation. We always give people steroids who are admitted to the hospital. And it's because it's been shown to improve the improvement in FEV1 and also shorten the hospital stay. In Britain, they use 30 to 40 milligrams by mouth. In the United States, we now use about 60 milligrams of a prednisone equivalent daily. It used to be we used 60 milligrams every 6 hours or 125 milligrams. You do not need that at all, much lower doses, and even oral, which they do in the UK. We use antibiotics if there's an increase in sputum volume or color change or other signs of infection. And if the patient's been in the hospital recently, we'll use broader spectrum antibiotics. These people are at risk for Haemophilus influenza, in addition to pneumococcus, and also gram-negative bacteria. Okay, steroids are very good. They reduce inflammation, they speed resolution, and decrease hospital stay. All right. Here's a really, really important thing that we have discovered in the last, now, I guess it's 20 years. Non-invasive ventilation, basically with bilevel, or what the trade name is called BiPAP, has been shown to be extremely effective for people with COPD. And there was a study, which is a classic study, which looked at this. It was a randomized controlled trial in France, in Europe, and they treated them with everything we talked about. Oxygen, they treated them all the same, but in the treatment arm, they added a pressure support ventilator, BiPAP. They did pretty high pressures, 20 is pretty high, and they gave oxygen to keep the saturation at 90%. And they used it 6 hours per day at least, and lengthened as tolerated with at least 2-hour per day break, and they could eat and talk with families, etc. And what they showed was that the medical, compared to the non-invasive positive pressure ventilation, the deaths were reduced and the intubations were reduced also. So this took off like wildfire, as you can imagine. There are now about 14 randomized controlled trials, and here's the Cochrane database systematic review, which looks at the relative risk of mortality of all the studies that were usable. The reduction in mortality was half, and the decreased need for intubation was about 60%. So I'm the director of respiratory care services at the hospital right over here, and this is the biggest thing that we have done in respiratory therapy probably in the last 50 years. So it is very important. Now, how do we decide who gets it? Okay, you have to have somebody who looks like they're fatiguing, so they're short of breath, generally alert and cooperative, although if your CO2 is high, you may be a little drowsy. You can't have a lot of cardiac problems, arrhythmias, etc., hypotension, and you're able to protect your airway, your swallow's good, and you can handle secretions. What we do is if a patient's pH is less than 7.35, which is just at the lower end of normal, or the CO2 is greater than 45 and they meet all those other criteria, we put a mask on them and we ventilate them in a monitored setting, which is either a step-down unit or an ICU bed. And in general, those people will not be intubated. It's pretty rare that they get intubated. We know that for very mild patients, so if your CO2 is 40, which is normal, and your pH is 7.40 normal, you won't get much benefit, so there's no use in trying. What's the lowest pH you might go to? Well, there is no absolute lower limit. But if I start getting to a pH of 7.10 or lower, I start to wonder whether I'm going to have much of a positive effect, and I follow them extremely carefully in the first hour or two. All right. So what do we do when they're admitted? We follow their response. So does their respiratory rate go down? How about the oxygen level, the exhaled tidal volume, because they're panting like a dog, right? We want to see a larger tidal volume with a slower respiratory rate. We'll follow their blood gases. We make sure, our therapists make sure that the leak is minimized and that they're not necrosing off the bridge of their nose. Rarely have a problem with gastric distension because you're blowing air in their mouth. And these are the kind of masks we use. They're all full face masks. So whereas at home, somebody with BiPAP or CPAP might normally be wearing a nasal mask, we use the full face mask. This has been studied, and the results are much better when you use the full face mask compared to the nasal mask. Okay. These are the kind of ventilators that we have in the hospital. They're much bigger and more powerful than the home devices that you see. Okay. All right. So I've mentioned that. All right. Okay. I think we can go on. All right. So non-invasive ventilation. Bi-level, so the generic name BiPAP is the trade name for one of the companies, very helpful in anything more than a mild COPD exacerbation. Okay. All right, so let's say we've gone through all of those outpatient treatments, the patient's on oxygen, they have very severe disease, and they come and they ask you, what about surgical options for COPD? And there are a couple of surgical options. The first is called lung volume reduction surgery, and I was the principal investigator at our hospital for a nationwide study of this. And what it is here are the lungs of somebody with COPD. Right? When you have COPD with emphysema, which means the destruction of the elastic lung tissue, the lungs get really big, right? Your chest wall gets big, the big barrel chest. You might have seen the Frank Netter picture, right, of the person with COPD and emphysema as the big barrel chest, right, and the flattened diaphragm. Well, there was a surgeon in the 50s who said, God, if we kind of went in there and we took out the worst affected parts of the lung and we made the lung smaller, maybe we could make that mechanical system, that big barrel chest, work better and make the patient less short of breath. Excuse me. And he did about 30 patients, but they didn't really have the surgical technique to keep them going, and he had a few deaths, so they kind of put it aside. But in the early 1990s, a thoracic surgeon said, well, now we have the way of actually stapling the lung and sealing it better. Let's try it on our patients who are waiting for lung transplant who may not make it because the waiting list is too long and not enough organs. So he did this. They did a median sternotomy, right, split the sternum, went in, and they resected the upper portions of both lungs. And this is the lung left inside the chest, and this is what they took out, which has these big bubbles, bullseye there, right? So they resected about 25 to 30% of the lung on either side, and they found that their breathing function improved, their shortness of breath improved, and it kind of spread like wildfire across the U.S. Until Medicare looked at it and said, my God, what are you doing? This has never been studied. So they studied it, and we did this huge study, over 2,000 patients around the U.S., moderate to severe COPD with an FEV1 less than 45, residual volume, so air trapped in the chest, emphysema, and very significant impairment of quality of life, and no heart disease, cancer, etc. And when we did this study, we found, and green means good, we found that people who had emphysema in their upper lobes and when you put them on a bike, could barely pedal the bike, could do about 25 watts for women and 40 watts for men. And if you've ever been on an exercise bike, right, it's barely any resistance at all for 1 minute, and they couldn't even do that. So if they had those two things and the qualifications that I mentioned before, they had an extension of life, and the odds ratio was 0.47 for mortality, meaning that you were more likely to live longer with the surgery than with medications, the control arm. And out of all the patients we studied, I forget, this represented about a quarter to a third. There were two groups that did really badly, you don't need to know about. There were two other groups where they either were really good at exercise or they had non-upper lobe emphysema, and those people had better exercise, but they had no mortality improvement. So this is the second thing that has been shown to improve survival in COPD. The first was oxygen that I showed you, which had a real bump. The second is lung reduction surgery for appropriate candidates. So that was kind of a big deal in doing that. It took 10 years out of my life, so it was a real big deal. All right, what about transplants? So people who have severe COPD can be candidates for lung transplant. And it used to be we only accepted people up to age 60, and then it increased to age 65, and now it's up to 70, and even a little older than 70 if you don't have a lot of comorbidities. So the geriatric population is starting to come into the arena for lung transplant. Lung transplant is not easy. Lung reduction surgery is one operation, recovery, and then you're done. Lung transplant is the surgery, but then you're on medications to prevent rejection of the organ, and you take somewhere around 18 to 25 pills a day for the rest of your life, and there are lots of complications from those. But if you have a low FEV1, or if you are rapidly progressing, disabling symptoms, have pulmonary hypertension, and I said less than 65, but it's now really 70 or even higher, you have a significant improvement in quality of life if you undergo lung transplant. But the problem is the survival is not different. So if you look at medically treated COPD, and you look at lung transplant, the curves are pretty similar. But your quality of life is better, and that was shown in the mid-1990s. And it's substantially better. That is, people are doing things that they weren't doing before, you know, and enjoying life. But it's a big, big issue. All right. So, to summarize, and then we'll get to all the questions, COPD is a rapidly growing problem. It is growing in the geriatric age group quite dramatically. Smoking cessation is crucial. Medications are largely for symptom relief, but some agents, inhaled steroids, can reduce exacerbation. Oxygen, when needed, meeting those criteria, is life-prolonging. Non-invasive ventilation for acute exacerbation is absolutely helpful, and I would say most ERs consider it standard of care now. And lung reduction surgery and transplant are options in very advanced disease. I would say if you look at the geriatric population, they represent probably a smaller percentage of people who go on to those advanced therapies, but I will tell you, I have had people who were 75 with lung reduction, and they loved it, and, you know, did all the things they wanted to. All right. So now questions. I have one already. Are there any issues with full face mask with patients with ocular issues and increased pressures? That's a really good question. Generally, no. There's an exhalation valve in the mask, which prevents too high pressures. Sometimes their eyes can get dry because there is flow of air in the mask, but we've never had any problems that taking the mask off intermittently would not help. We've never even used artificial tears or anything like that. If the patient was comatose, not blinking, that would be a problem, but you cannot be unconscious and get non-invasive ventilation, because if you vomited, you'd be unable to protect your airway. So I'm going to try to calculate that. Oh, thanks. Fantastic talk. Thank you. Let me see. Did you say at the Air Force Academy it was 590? Because I'm going to calculate that right now. All right. If we use 590.21, it's 590 minus 47, PaCO2 over 8. So 590 minus 47 is 43. Now I need my calculator, sorry. 590 is correct, okay. Here we go, I'm coming up on it, 590. Okay, oops, not now. Okay, 543 minus 50 equals 4. Oops, excuse me. So 543. 114 minus 50, 64.03. Ooh, okay. For you at the Air Force Academy, your alveolar O2 would be 64.03. Usually you might hyperventilate very slightly, and so your arterial O2 would be about the same, which would give you a SAT between 90 and about 93%. So, yeah, that's why you never want to have COPD and live at high altitude, because you'll be wearing oxygen a lot earlier. Okay, all right. Homer seniors, more non-smokers and increased incidence of COPD are environmental factors responsible. Well, that's a really super question, because there are more non-smokers now, but if you look back 30 years ago, we were kind of at the peak, and it takes a long time for COPD to come about. So what we should see, one hopes, is that with fewer smokers, we'll have less United States citizens with COPD. That is not true around the world, where pollution and indoor cooking are huge. So I would imagine, if you're living in Beijing, that you are at substantially higher risk, even if you do not smoke. Okay. How much exercise is appropriate for someone with COPD? That is fabulous. So, pulmonary rehab is fantastic for patients with moderate to severe COPD, because it teaches them about the medications, their disease, and also it monitors them during exercise, so you can get an idea of what is good for them. Certainly you can buy oximeters now very cheaply, and I would not press them to where they desaturate with exercise, or if they do, they probably need to get oxygen. But people can do a fair amount, and you can definitely improve the exercise performance with rehab and exercise. Okay. Lung reduction surgery is life-prolonging and proper candidate. How much time does it give a patient on average? That's great. We do not know exactly how long. The data from that was two-year data. So we know at least at 2 years that the survival was greater in the treatment group. They have continued to follow some of those patients out, but we don't have the final kind of publication of the longest survival time. In my own experience, I would say that it gives the patient probably 3+ years, you know, where they're really good. And sometimes it can be spectacular how good they are. But it is not indefinite because it doesn't cure the disease, and that will progress. Okay, patient with isocyanate exposure, age 54, never smoked, lung sats 86 at rest. Would you recommend full face mask on daytime hour? Full face mask oxygen, I'm assuming you mean. I would use, a full face mask is really hard to use during the day, not so much at night. I would use a oxygen conserving device. There are two kinds. One is called the oximizer, and then there's the mustache cannula. And those can give you oxygen that's nearly as much as a mask, but you can wear it. So it's an oxygen conserving device. That's what I would use. Yeah, isocyanate, right, that causes severe obstruction, and it generally is associated with asthma, but if it's severe chronic, it kind of falls into the COPD. Oh, alpha-1 antitrypsin screening, great. That's a great question, thanks. I didn't talk about that. So alpha-1 antitrypsin deficiency is a genetic cause of emphysema. It's less than 5% of all cases. The emphysema is found in the lower lobes when you have alpha-1. In smoking-induced emphysema, usually the emphysema is in the upper lung zones. So if I have a patient who comes in and has lower lung zone emphysema, and it's coming at an earlier age, say maybe in the 40s and early 50s, then I would do the screen for alpha-1. There is replacement therapy for alpha-1 antitrypsin. So you go in and you get IVs and you get the enzyme back. Alpha-1 antitrypsin, we believe, works by preventing the release of enzymes that can degrade the lung by those inflammatory cells. And so it's never been studied in a controlled trial, but registries seem to indicate that you do have milder disease if you get the replacement therapy. So alpha-1, lower lobe disease, younger patient. All right.
Questions here in the room?
Kalispell VA is typing. I didn't know there was a VA in Kalispell. That's fabulous. Oh, good. You are very welcome.
Thank you.
Yeah, you're very welcome.